Hello everyone, welcome to Mid Adventure. In this episode, we'll be having a brief discussion on approach to agitated patient. Agitation is a state of heightened arousal. It can range from subtle increase in psychomotor activity to violence. It's a common encounter among emergency care providers. It's a non-specific symptom for several causes. Risk factors for agitation include male gender, substance use, psychiatric illnesses, and prior history of violence, especially incarceration. Next, we'll see etiologies for agitation. Remember, this list is not exhaustive. Medical causes for agitation include endocrine disorders like adrenal insufficiency, metabolic disorders including hypoglycemia, electrolyte imbalance, acid base abnormalities, infectious causes such as meningitis, encephalitis, sepsis, trauma like head injury, neurological conditions including dementia, intracranial tumors, and other causes like hypertensive encephalopathy, hyperthermia, hypothermia, hypoxia, hypercarbia, and shock. The next category is substance use. Illicit drug withdrawal or intoxication or adverse drug reactions like steroid-induced psychosis are also other etiologies for agitation. The next category is psychiatric illnesses. Psychiatric illnesses like PTSD, schizophrenia, anxiety disorders, bipolar, and personality disorders are also causes for agitation. In addition to the previously listed three categories, psychosocial factors like extreme stress are also causes for agitation. It's always important to keep in mind that agitation can be a symptom for severe medical conditions. Therefore, it's critical to pick up medical red flags when assessing patients with agitation. Medical red flags include vital sign instability, labored breathing, signs of trauma, neurological features like seizure, focal neurological deficits, severe headache, cognitive impairment, new onset psychosis. Heat intolerance and unintended weight loss are also red flags. Now, let's see how to approach patients with agitation. Management of agitated patients prioritizes safety, systematic assessment, non-pharmacological calming strategies, targeted treatment of underlying causes, judicious pharmacological therapy when needed, and strict limit on restraints. The objective is to restore safety and orientation while minimizing harm and preserving the patient's dignity. The first step is immediate safety and scene management. The first priority is safety for everyone, including patient, staff, and bystanders. The clinical team should secure the environment by removing weapons or hazardous objects and limiting the number of people in the room to essential personnel. Early assistance should be summoned, including security and additional clinical staff trained in behavioral emergencies. Team members should adopt non-threatening body language, keep a safe distance, 2 arm lengths apart from the patient, and avoid cornering the patient. Clear roles should be assigned. Who communicates, who monitors medical status, who documents, so that actions are coordinated and calm. These steps reduce escalation risk and form the foundation for subsequent assessment and interventions. Next, rapid parallel assessment. Assessment must proceed quickly and in parallel with safety actions. The primary goal is to identify immediately reversible medical causes of agitation, check airway, breathing, circulation, assess oxygen saturation, and provide supplemental oxygen if hypoxia is suspected, measure blood glucose, and correct hypoglycemia without delay. Evaluate for sign of head injury, stroke, or focal neurological deficit. Screen for obvious intoxication or withdrawal, and treat per protocol. Consider infection if the patient has fever, tachycardia, leukocytosis, metabolic derangement like electrolyte imbalance, uremia, hepatic encephalopathy, pain, urinary retention, or constipation, any of which can provoke agitation or delirium. Obtain rapid vital sign monitoring, temperature, heart rate, BP, respiratory rate, saturation, and if possible, ECG to check QTC before antipsychotic in high-risk patient. These checks should be done while the escalation is attempted. They are not mutually exclusive activities. Communication in structured verbal de-escalation is always the preferred initial strategy and should be attempted in nearly every case Key elements include approach calmly at eye level with open palms visible and non-threatening stance. Use short, simple sentences in a steady, low voice. Avoid arguing, bargaining, or issuing ultimatums. Validate emotions. Use statements that acknowledge distress. Then offer help. Validating doesn't mean agreement with harmful behavior. Offer limited, concrete choices to reassure a sense of control, like, would you prefer to sit here or there? Avoid hidden movements. Allow personal space. Do not touch without consent. Avoid sudden movements. Use active listening and reflect back what is heard to show understanding. If a language barrier exists, use interpreter services if available, rather than assuming or relying on family for translation. De-escalation is a skill that takes practice and should be part of staff training. When verbal approaches are effective, they reduce the need for medication and restraints. Environmental and psychosocial modifications concurrent with verbal strategies reduce agitation triggers. This includes reducing noise, dim bright lights, and remove crowds. Provide a seat, a blanket, or glass of water if appropriate and acceptable to the patient. When assessment identifies a medical or substance-related cause, treat it promptly. Treating the root cause often produces the most durable improvement and reduces reliance on sedating agents. Medication is indicated only when the patient remains dangerous to self or others, when non-pharmacological methods have failed or not feasible, or when the patient's medical condition requires rapid sedation to allow necessary care. The team should select agents according to the suspected cause of agitation, patient's age, comorbidities, and risk factors. When the medication is given, documentation of the indication, drug dose, route, and response is essential. Physical restraint is a last resort and may be used only when the patient presents an imminent risk of harm and less restrictive measures have failed. Restraints can cause physical and psychological harm and are not therapeutic. Therefore, their use must be justified, minimized, and carefully recorded. In summary, management of agitation includes safety first, secure the scene and call for help. Rapid and parallel assessment for reversible medical cause is essential. Verbal de-escalation and environment modification are first line and often effective. Medicate only when necessary. Choose agent based on cause, age, and comorbidities and monitor closely. Restraints are last resort. Document, monitor, and discontinue as safe as possible. Thank you guys for listening and watching this video. Hope this episode has been helpful. Please don't forget to like, share, and subscribe for more.